That's right.
Okay, welcome everyone to our Thursday DMICE conference. And as you've heard me say before, we do different things at this conference. One of them is students presenting their proposal defense. So presenting their plan for their research and giving us a presentation on it, and then we give them feedback and so forth. And then, like the actual defense, they after this, the student, the candidate, and committee will go into 123, and I guess they're going to have to follow some circuitous route because of whatever's going on out there. Anyway, so our presenter today is, he's actually already Dr. Chris Hoekstra because he has a Doctor of Physical Therapy degree, but one doctoral degree is not enough, so he's pursuing a PhD in our program, which is actually nice. It lets us fund him as a postdoc fellow instead of a pre-doc fellow. So he got his DPT degree from Pacific University, undergraduate degree in biology from Willamette. So he works as a physical therapist. He's also been involved with a company having the title of Director of Knowledge Management. And his informatics research interests are in organizational behavior and its impact on the perceptions and decision-making processes of clinicians and managers. So he's going to give us his presentation.
Thanks, Bill. And thank you all for taking the time to come today on this beautiful day outside. So we'll get you out as quick as we can. So my dissertation proposal, my research idea is around the impact of context on how managers, so specifically the managers in physical therapy practices, utilize information systems to make their decisions. So to start that process, what I want to do is kind of get you all in the mindset of a practicing physical therapy manager. So if you will, envision this is you here. You're a physical therapist by training. The majority of your care, your time in your week is responsible for patient care. So over 50% of your time, more like 100% of your time is seeing patients full time. In your spare time, then you do your management duties. And that includes things like personnel decisions. So you're hiring and firing individuals, implementing corporate strategy, looking at the financial performance of the business unit that you oversee, doing marketing, so trying to get new patients into your facility. You're responsible for ensuring patient satisfaction, and you're responsible for staff development. In addition, you're responsible for overseeing the clinical quality, the care that your providers give. And so I bring this laundry list of information here is to say that a practicing manager in physical therapy has lots of masters which they serve, and they need to divide their time among lots of different tasks that are very disparate. Now, if we take all of these disparate things they have to do and we put around them information systems, now we have a whole other milieu that they live in. So this manager has to simultaneously navigate practice management systems, quality management systems, the internet or intranet to find information about policies and procedures, that sort of thing, HR systems, client relationship management systems, payer reports and their various systems, and oh yeah, the EHR. So they're simultaneously, when they have questions doing all these various tasks, have to go to disparate, sometimes unified, but oftentimes disparate information systems to find the information that they need to do their job. So if we now kind of hone in on clinical quality, that's the focus of where I'd like to aim. There are certain systems in the PT world that they'll use for this. So there's sometimes just EHR-based reports. So you might pull information out of the EHR, say through a crystal report or something like that, that tells a story on clinical quality. More commonly in the outpatient side, which is kind of where I'm hoping to focus, they do have dedicated quality improvement and quality management systems. They're freestanding systems. Sometimes they relate or interoperate with the EHR systems. Many times they don't. There are a few registries, very hyper-focused registries related to physical therapy. These aren't as robust as many of the medical registries or the disease-specific registries. oftentimes these become really a repository. So the data goes in, but oftentimes the data doesn't come back out to be used for improving clinical decision making. Also, they're integrated dashboards, so whether they get this information and they pull it all into something like a Tableau, or they may have some hooks into the Tableau to their other systems to deliver up the information, or they may just simply do manual reports, Excel spreadsheets that someone codifies by hand. So there's lots of different systems, and within different systems, there's lots of different variants of a single system. So I show all of this information to say there's lots of masters this individual is serving. When we get into clinical quality, there's lots of variety in that world, and we need to understand what that is if we hope to really better understand how we can do it better. So that really gets to my clinical questions. So my clinical questions started pretty broad at the top, and just what are those influencers of prioritization for these clinical managers? So what is it that makes them do what they do and not do what they don't do? There are certain influencers on their life. From there, if I can focus it down and say, okay, let's all these distractions, now we have management of clinical quality, now we can start to hyper-focus down on some other focused questions. So in that box of clinical quality, I'm interested in what are their information needs. So when they have a clinical question around quality, whatever that might be, we'll talk about some specifics in a moment, what information do they need to make a decision on clinical quality? Second would be, what are their facilitators and barriers to actually using one of these clinical information systems to answer that question versus doing something else to answer the question? And then more hyper-focused to that is what are the contextual factors that maybe aren't apparent to them that also influence their use or disuse of these systems. And that really gets down to the hyper-focus of what I like to emphasize. So I'll take you through kind of 3 stages through the rest of my talk today. We'll start off with some definitions, specifically defining what I mean by manager, what I mean by quality, and then what I mean by user acceptance of a system. Then we'll go through some aims of my study, and then we'll go through specific methods to finish out. So when we talk about manager, a manager can serve multiple roles. We saw those different stakeholders that they have to serve, but simultaneously they're also serving multiple roles. Manager means different things, or leader means different things. So Mintzberg in the 70s recognized that leaders oftentimes are serving 3 main roles simultaneously. So they're the interpersonal leader, they're an informational leader, and then they're a decisional leader. And we can describe that a little more granularly to say that interpersonal leader is more that liaikoka, the figurehead, the liaison back and forth. They're the big head cheese. You now have the informational leader who's responsible for monitoring information, disseminating it to the masses, and then also being the spokesperson for the company on what information is most valuable. And then you have that decisional leader who's making the decision. So that entrepreneur, they're kind of handling all the disturbances in the organization. They're the negotiator, that sort of thing. I could spend an entire dissertation research project just understanding what it means to be a leader in physical therapy. So I chose to hyper-focus down really on the informational leader. So if we think of the manager as the holder of what's important to the organization for information, how do they see how they're doing on those metrics that the organization sees are valuable, how do they get information back to the frontline practitioners to know how they're doing. And they have to lead in that, so I left the leader piece up there as well, but really leading with the focus on the information that they're trying to get to the masses. So from there, if we pause and we go off to now, what do we mean by clinical quality? Because we've now defined what's a manager. Now we have to define what do we mean by quality if they're going to be managing quality. And this is really contingent on what stakeholder you're talking to. So these groups aren't mutually exclusive, but we know that each of these groups has an area of kind of tacit focus, that if they exclude all the secondary things, their main focus will fall kind of in this area. So patient being service quality. We've got lots of anecdotal studies of patients that like their care, even if they don't get a good outcome, but they felt cared for. It was a nice office. The people were friendly. They liked being there. They felt valued. Where maybe a provider has more of a focus on, did I do the right thing? Did I do the right thing with skill? So it's much more of a tactical, skill-based. Now, not that they don't care about the service quality. That's certainly important. But a main focus may be more on the technical skill of the thing that you deliver in your specialty. And then we have the payer, who now is going to be the arbiter of the money. So they're not this may be a private payer. This might be you, the taxpayer, being the payer through the federal government. Or this might be the individual is also a payer. if they're cash paying for their services. But now you put in to say, yeah, I want you to have great service. Yes, I want you to get the best quality care as defined by the best service, but also we need to do it for the least amount of money possible. And then finally you have the organization. Basically, if you think of it from a business sense, they have to please all of these individuals. So if you don't have happy patients, you're not going to be in business. If you don't have anybody to pay the bills, you won't be in business. And if your providers don't enjoy working for you, you won't be in business. So they have to make sure that each of these individuals is being served. So this puts the manager in an interesting mediator role. So they're the face of the organization to the day-to-day operations. This individual has to help figure out what are the needs of those stakeholders and ensure those needs are being met. So that's, from the quality standpoint, where the manager sits is in that middle role. But part of my research is really going to focus on where do you focus right now, and then more importantly, why do you focus there? So first, defining what it is, but then second is why do you feel you do that? What are the stakeholders that are influencing that? What are the organizational structural things that are making you focus on that aspect of quality? So we'll pause at that point and now go into technology acceptance. So we've talked about a leader, we've talked about quality, and now we need to talk about use of a system, because in the end, my question is a leader leading quality or managing quality by using a clinical information system. So there have been multiple studies on how do we define acceptance of technology. Most of these models have drawn back to the work of the theory of reasoned action, which basically is a psychological methodology or a matrix that says ultimately we have an attitude towards a behavior coupled with what the people around you think about that behavior. And if both of those things agree that you should do that behavior, then you'll probably intend to do that behavior. And then if you intend to do that behavior, you probably, in the end, will actually do that behavior. So it's this behavioral intention flow. So you think it's a good idea, the people around you think it's a good idea, which makes you want to do it, which makes you actually do it. They kind of step through that way. Now they've studied this model in isolation, and they've said, okay, we have the same predictors up here, and then a lot of other models have tried to say, well, what do we have back here that can predict the attitude? Or what do we have back here that can predict subjective norms? And so we have individual beliefs and also your past experiences with that activity that are your background that shape your attitude. And then we also have the same sort of thing, the organization, their experience with that activity in the past, and that shapes their subjective norms. And those together collectively all work to influence whether you think you should do that activity or not. And they've studied this with respect to use of technology, both in the consumer world, in the business world, and in healthcare, and have shown that this can predict with decent predictability. So between 20 to 40% of the variance can be explained by this model if we look at use of various systems, if we look specifically in healthcare. But what was attempted was to say, can we take that model and refine it and make it a little more specific to technology? This is not specific to technology. This is any behavior. So now this is specific to more technology. If you see here, we have this attitudes towards behavior. That's the same thing we had right here. So the technology acceptance model said, we're really going to focus on this one. We don't think subjective norms are as important. This one's more important, so can we work on some predictors of that? And so what they came up with as their base model was that if an individual thinks that a system is going to be useful for their day-to-day job, so it's going to have good performance, and they think it's going to be fairly easy to use, those two things together will make them think it's a good system, which in the end will make them want to use the system, which will make them use the system. That's TAM. And then they tried to put lots of external factors back here again to just say, can we predict these two main constructs that we think are driving their intention to use the system? And this did a bit better, so now we're getting up into the order of 40 to 50% predictability of using the system. But this is one of many competing models, and so now what's happened over the last 30 years is lots of researchers and business folks have said, we think we can do this better by adding lots of different things out here, or tweaking it just the right way. And all of those have had varying degrees of success or improving the variability. But now we have about 14 competing systems, all of which that are trying to measure the same thing, which is using some sort of technology. So here's where it gets a little bit crazy. That ultimately we have those same three factors here, the perceived usefulness, ease of use, behavioral intention, and system use. But this is the third version of TAM. Now we've added all of these extra factors, these antecedents that predict back here, lots of moderating effects back here, and this only gained us 1 to 2 points of better explanation of the variance. So the model's become much more complex, but it's not explaining the use much more. So we've lost some of that parsimony of what we're trying to get out of the model. And so this kind of brings me down to the model that I'm trying to use for my study. The reason I show you this background information is there's lots of models I could have chosen for studying the use of technology. The unified theory of use and acceptance of technology, I'll only say that word once. Now we'll say UTOUT after that. So UTOUT basically said, can we take these 14 competing models, which all kind of look like this, but are slightly different? Can we all boil them down to some common constructs, try to make it a little simpler, and can that still do a pretty decent job of explaining the variance of the use of the system? So this is the UTOUT model here. In its simplest form, basically says we have that same performance expectancy here. That's just like on TAM. We have effort expectancy here. That's just like on TAM. They added back in social influence, because a lot of the other models did say where you work and what the people around you say influences your decisions. And also they added in individual facilitating conditions. So things like, if we give you training to use the system, are you more likely to use it? If we incentivize you to use the system, are you more likely to use it? If we give you nice computers that aren't kind of archaic and hard to use, will that make it easier to use the system? So we can add lots of facilitating factors, as well as habit. So just if you've done it for a long time, are you more likely to keep doing it or thinking that you should do it just because it's the rote thing that you've been doing? Interesting thing is this UTOUT model explained between 40 to 60% of the variability of use of the ultimate system in the end. What they did in their second version is they added in effect modifiers. So simple things like age, gender, experience, and then also habit as an effect modifier didn't change the base model at all, just basically put in these other interaction terms. And by adding those in, increased up to about 70% explanatory power of the end use of the system, or behavioral intention. And so my contention here is we can take a simple model, but then we can add some factors around that that we think influence how that model operates in real life, and that'll make the model a better predictor in that area that you're studying. And this is a concept of contextualization of a model, and we'll talk about that in a little bit. So that contextualization comes back to this common thing that we've all seen in our introductory informatics course, that the concept that an individual thinker plus a computer system is going to net us a better outcome than the individual thinker alone or the computer alone. So that interface between them yields us a good outcome. This is only partially true. This is great, but this doesn't happen in a vacuum. So this same process of person interacting with the computer happens inside of what we call a socio-technical model. So this individual is using a system, but they're a different type of person. They have characteristic traits that they bring to the table. They're in a system that has a certain structure, an organizational hierarchy, an incentive structure, a social structure. They have a specific task that they're using the computer for. So this process isn't going to be the same for all tasks. And then ultimately they have different technologies. Every technology isn't created the same. So it's really the interface between all of these four factors, the person, the system, the structure of the organization that they work in, and the task with which for which they're using the system. All of these things interact together to then predict how this person is going to use a system or the effectiveness of the system in the end. Now, what's been studied a lot have been people and technology. Most of the TAM research really has looked at an individual using a very specific information system, and how can we predict that. What they haven't looked at are these other two factors of you're using it for what, or you're using it in what sort of setting. And these are really the contextual factors that are intriguing to me, as I can take the same person and the same technology, but put them in an entirely different organization, and that predictive power is likely going to be entirely different. Or I can take that same person in the same organization, but give them an entirely different task, and their performance is probably going to be different. So we need to really understand all four of these factors. And I'm really interested in the task and the organizational structure for that. So that really gets me to my aims. And the aims of this really are threefold. So if we start with the first one, and these all have contextual connections. So the first one would be a task context aim. Really what I'm interested in understanding is what are the information needs of the managers and what are their seeking behaviors right now to answer those questions. So that's not been studied in the literature at all for physical therapy managers. It has a little bit for healthcare managers, but not much at all, and then maybe a little bit more for practitioners, so medical practitioners understanding their information needs and seeking behaviors. But first of all, we just need to understand what questions do you have, what are the stakeholders around you that are shaping those questions and shaping the way that you're managing clinical quality, and then how do you go about answering those questions or coming to your decisions in your day-to-day work. If we can understand that, then we need to understand the organizational context. So what is it that you perceive and things you don't perceive that can facilitate getting those answers that you need and really managing clinical quality as you define it? Or what are those things that are barriers to that, that are slowing you down or keep getting you off track and not allowing you to manage quality to the way that your organization defines it? And I use that term as you define it a bit loosely because physical therapy, unlike in medicine, has kept a relatively loose definition of quality. So medicine is congealed around some of the meaningful use concepts, and then we have NQF and ARC and those sort of things that have given some specific measures that are specific to medicine. Many of those don't apply to physical therapy. So physical therapy has a few of those, but they've also developed a lot of their own. So just like they have lots of varying systems to measure quality, they have lots of different measures of quality that aren't congealed around common themes. And so in these organizations, it's not my intent to understand what's the empirical definition of what should be quality for physical therapy. It is, what do you define as quality, and how does that relate to other organizations? But once you've defined it, how are you managing it, and how are you using information systems in the act of managing that? And then the last one here is to understand this UTOUT system. It's not been studied in managers of physical therapy. It's frankly never been studied in physical therapists in isolation. It's done therapists, which have been PTs, OTs, and speech therapists in hospital settings. It's never been looked at in the outpatient setting. So really I need to understand, is it even applicable to the setting of physical therapy? And we can really do that two ways. We can do it qualitatively, and we can do it quantitatively, and I'll talk about that in the aims. But I'm really interested in understanding how the manager kind of operates in their day, what are their questions, and how do they go about answering those questions and making decisions. How does the context of the organization affect that behavior? And then how does that maybe relate or not relate to the UTOUT constructs that we showed here a few slides back? So these first two will combine together in my first phase. There'll be a two-phase mixed method study. First two will combine together into one phase. And then this third one will span both phases, and I'll show you how in a moment here. So what I need to do, though, before we get into the methods, is just to talk about contextualization of a model. That is the aim of what I'm trying to do, is understand how I can take this freestanding and previously validated model of UTOUT and contextualize it for physical therapy managers in the outpatient setting. So the idea of contextualization of a model is you have some base model. We'll take UTOUT as our base model. So you have that model living in isolation. But now you put it into practice, so you add certain task context to that model. So using some sort of software for something. That's your task. And understand how does that influence how the model behaves compared to how it may have behaved in the literature in another setting. And then we also put that task inside of the environment of an organization and then try to understand the influences of the organization on that model and how do those influences change the model. So first of all, I just need to understand, does it still work when I put it in that environment? That's kind of my main focused aim. But then exploratory aim would be, can I also play around with what happens when we add certain factors that come out of my first phase? How do those affect how the model behaves in this setting? So the way we'll do that, we'll have, again, a mixed method study. We'll have both quantitative and qualitative aims. So phase one, hoping to take about 6 months to do this. We're using rapid qualitative inquiry. So rapid qualitative inquiry is a qualitative ethnographic method that's team-based. So what this allows us to do is take a team of 8 individuals that we've established that have differing perspectives, differing experiences, and differing expertise, in addition to local co-investigators. So as we go into these organizations, we've identified, or I have identified, a navigator at each organization that we can check our inferences on. So we're thinking this, we're seeing this, we're hearing this, does that make sense? What aren't we asking that you think is important? They can give us an insider's perspective. So what rapid qualitative inquiry allows us to do is start with one main methodological focus, but as we learn more information, we can shift just a little bit to explore these emerging themes that come up. So our methods are fairly set at the beginning, but they're flexible to allow us to explore new areas as they come up. So how we do that is we use purposive sampling of managers and other leaders in the organization, both those that lead quality as well as more the executive level that are setting strategy at a bigger level, as well as observation. So can we observe these managers using their information systems, or however they're answering their questions or making their decisions on clinical quality? Can we watch them do that and ask them questions about that process? It's an iterative approach, so we'll go in with some themes, we'll test those themes, we'll come out and what did we learn, what do we need to change, and we'll go back in and test those again, come back out, what did we change, what did we learn, and what do we want to test the next time. We can go in and out both within one organization, but also between organizations as well. And I'll show you in a minute how we've broken down these organizations. This uses a grounded theory approach as its core. So we go in somewhat blind, saying we'd like to, in true ethnographic fashion, we'd like to go in and experience what it's like to be you in your job. And we'll draw some themes based on that experience of talking to you and watching you. But also, we can use UTOUT as a bit of a base theme, so we can seed some of the questions, and some of our base inferences on themes can be, well, we think probably they're going to talk about systems being easy to use. We think they're probably going to talk about systems serving their needs. They're going to talk about social influence. We may not overtly push that upon them, but we're going to be listening for that and looking for that. And that's how we can still keep a grounded theory focus, but also test whether UTOUT is showing up in what we're hearing and our inferences. And then at the end, we use member checking, so we go back to these individuals and we say, here's what we heard and here's what we're thinking. How's this sit with you? What did we miss? And what do we need to check the next time? So we get, again, our perspective, which is now team-based, which makes it broader than what I could do on my own. But also now we get their input that also shapes our themes. So if you think about what we're doing, in a truly quantitative study, I could pose a hypothesis, I could set methods, and I could start here and I could test my methods straight down and get to the end in a very linear path. What rapid qualitative inquiry allows us to do is to say, I'm starting here with a kind of an idea what I might see, but I'm leaving it purposely open. And now we're going to explore in our first site a bit of a methodology, but about 2/3 of the way through we might say, oh, we totally missed this. We need to look at this over here because we didn't even consider that in our first theme creation. So now when we do site 2, that's informed by what happened with site 1. So now we change our methods slightly and change our focus. We can do that through each of the sites, and what that allows us to do is, rather than a nice, clean, straight path, which would be free of bias, which would get us there quickly, which would take away confounders, which is all great, but it also, that's at the expense of understanding the breadth of the information that we could get out of the organization. And so what rapid qualitative inquiry allows us to do is to be rigorous in our methods, but still get breadth of information. We're not trying to get rid of bias, but we're trying to understand that bias is there, and can we at least shine a light on it and understand why it's there, and that will shape the themes that we create. So these are the organizations that have leaned in to participate. So there's 5 organizations. I chose 5 organizations of differing sizes because there is at least some literature that says bigger organizations have different information needs than very small organizations, or potentially rural organizations have different needs than urban organizations. So we chose organizations with 800 facilities nationwide, all the way down to a practice in the Northwest with 3 practices, and then folks in the middle. We have some that are rural, some that are urban. OHSU has agreed, and so we have a hospital-based system, and then some private practices as well. So we tried to get a variety so that we can understand what is kind of the breadth of practice of outpatient physical therapy in the U.S., and then we don't get hyper-focused just on one organization that may have its own limitations and failure to have generalizability. So that's phase 1, to understand those information needs, understand the facilitators and barriers to using these systems, and see if UTOUT basically fits in a qualitative sense. Aim 2 would be to now specifically go at, in a quantitative focus, to say, does it actually empirically fit based on data that we can look at from participants? The way we can do that is through a survey. So we can survey 6 constructs of UTAUT. So those are based upon 23 questions that have already been validated in past research. So there's a questionnaire that a lot of the developers of UTAUT have used in follow-up literature to test the constructs of UTAUT. So we'll take those 23 questions. If we get some constructs that come out of phase 1 that we think are interesting and we think might be contextual factors that we'd like to explore, then we can feed those in as well. All of these will be measured on a 7-point Likert scale. And then there'll also be demographic questions that allow us to do some of the, again, effect modification, but also just look for differences amongst different aged individuals, gender individuals, different experience levels, and organizational size. In past research, these have all been shown to affect how the model performs. So the way we'll do this, plan on using structural equation modeling, so specifically covariance-based structural equation modeling. There are some assumptions with that form of structural equation modeling, so I don't know what the data is going to look like until I get it back from the surveys. If it comes back and it's really skewed or really non-normal and we can't transform it, or I get a very few number of responses back, we may have to use another version which is called partially squared, which is a non-parametric approach that would allow me still to get inferences, just a little less rigorous test of the validity of those inferences. Primarily, it's a confirmatory-based approach. What I want to look at, again, is does the base model of UTAUT fit with managers of physical therapy? But we'll also have an exploratory aim at the end. So if some of the questions that I seed from phase 1 have decent psychometrics, I can feed them back into the model and see if they do have an effect on how the model performs. And then I'd also like to hold out a portion of my data, so 50% of the data will be held out to do cross-validation to make sure that as I fit to this model, I don't overfit. We can come back at the end and make sure that it still fits in that holdout data. So again, this is the base model that I like to test. This would be the primary aim of the second phase of my research, is just to say, does this actually work with outpatient managers and physical therapy? So then you'd ask yourself, well, why are you using structural equation modeling? Because it seems pretty straightforward that if I have this, I could just use multiple linear regression modeling, and it would be a little simpler way to do that. So basically, we just get, if I just took performance expectancy and effort expectancy, I can just put beta weights onto each of these. Maybe I add societal influences and all my other ones, add them all together, and I could predict behavioral intention. The problem is this is a unknown latent construct. So we can't actually measure effort expectancy. I can't just go in and say, how hard is it for you to use your system? That's maybe only one component of effort expectancy. So another way to think of this is maybe we'll use the concept of depression to make this more generalizable to something clearer to everyone. So you can't just ask a person, are you depressed? That's one component of depression, but there are multiple factors of depression that each can be tested with a different battery of tests. So when we put all those battery of tests together, we can now, from all of those, infer, okay, this is a level of depression that a person has. But that actual depression isn't directly measurable, just like these. So we have to have these questions that I can ask in a questionnaire that we think loosely relate to this, but don't totally relate to this. And that's what structural equation modeling allows us to do, is simultaneously test this outer measurement model of how do the questions relate to some common construct that we think they should relate to, but then also how do these latent constructs relate to one another in a path model to predict some sort of outcome down here, which is, in this study, going to be their intention to use the system. I'm not actually looking at their actual system use, because each system is different. We can't actually study logs in all of these organizations at this level to do that, and you would need a longitudinal study to look at that, and I don't have the time and the resources within the confines of my dissertation to do that. So we're looking at behavioral intention, which is fairly predictive of actual use in past studies, so we're going to focus there. This would be more the exploratory phase. So if we show that that one model works, or if it doesn't work, but I have some other factors I can try, then I'd like to take factors that I find in phase 1. So was there something that we thought was really specific about the task of a manager managing quality that we could feed into this system, into the interactions, and find out if it has an effect on the model? Or are there some things we heard about organizations, really big versus small organizations, or different leadership styles, or incentive strategies? Are there other things that we could potentially feed in to see if they impact how well these already established factors predict behavioral intention? Also sticking in here, system satisfaction. There is some research to say that performance expectancy and effort expectancy can relate to system satisfaction, even if they don't relate to behavioral intention. So it might be interesting to explore down here, if these don't actually directly predict behavioral intention like we think they do they at least predict system satisfaction? So it just gives me some other places to explore, which really doesn't give me perfect answers, but gives me now the next step of where I'd like to go in future research to explore these a little more empirically. So the way we do this is through a sample, a survey sample. So I can send out email invitations. The organizations that I'll be using in phase 1, there are 900 managers as part of those organizations, so we'll invite all of them to complete the survey. I'm also a member of the American Physical Therapy Private Practice section that has 4,000 members that I have access to their mailing list. We can send them an email survey invitation. As well as I'm presenting my phase 1 results next November. Hopefully I've submitted. Hopefully we'll get in. I'll be able to present there. That'll be at least another aspect where I can do a platform call to say, here's the information from phase 1 of my research, and if you'd like to participate in phase 2, here's a way that you can do that. So that gives us a total of potential 5,000 invitations that go out. Assuming we only get 10 to 40% response rate, that leaves me 500 to 2,000 surveys to deal with. Now, you'd ask yourself, is that a good number? Is that a bad number? If I did an a priori power calculation, and it said, based on the number of indicators I have, I should be okay power analysis with medium effect size with 237 responses. So why do I have 500 to 2,000? Again, cross-validation, I'm going to take half of those out to be able to cross-validate. So now we're down to that on my low end, down to 250. There's also within the SEM world been this rule of thumb, the rule of 10, that basically would say you need to have 10 observations for every one of the factors that you have. So that gets me in the ballpark right here. And the last piece is there's been a couple of studies that have done ex priori power analyses comparing to what your a priori power analysis said. And most SEM studies are woefully underpowered. And so oftentimes this happens when your data isn't perfectly normally distributed, or it's a bit skewed, or you have some covariance that you didn't account for, or outliers. And we know that's probably going to happen with the Likert data that I have. And so we may need to have higher sample size just to pick up differences there. So that just tells me that number is probably in the ballpark of where we need to be. So limitations to wrap up here. This is looking at planned versus spontaneous behavior. So it's really looking at, are you planning to use your system? There's lots of spontaneous things that happen in life that we can't account for through these questionnaires. So I'm looking more at their planned behavior only. Also, it's focused on behavioral intention and not the actual behavior of using the systems. Again, I don't have the time nor resources to study their actual system use for this phase of the study. This is more exploratory and making sure the model fits. And I'd love to extend it at a next level to look at this longitudinally to see, do they actually use the system? Or better yet, can we intervene with some of the recommendations that might come out of this study? Can we take an organization, look at how they're using a system, now intervene and see, can we change system use by applying some of the things we learn here? The model is focused on an individual's action and not a group action. We're taking a leap in that socio-technical model to say that individual's action is shaped by the organization and that individual is representative of all people in the organization. But we know that an organization is its own beast, and we're not studying the organization as a whole. And so we'll get some individual biases, nesting problems with this as well. We know that. Limited out to outpatient PT and primarily in the Northwest. So generalizability would have to be checked. This is very hyper-focused on where my study is going. And this is also a cross-sectional design, so all the limitations come with non-longitudinal studies. We'll have to temper my security and my inferences based upon this. And then this is also, phase 1 is based upon organizational interviews. We're having a navigator get us in. We're interviewing individuals in their organization, so they may feel less than open to give all of their opinions. They may feel they have to give more of a positive light of their system than actually is there. So we just recognize that might be there. And then on the survey, it's a self-reported survey. So that may not be the actual person's intention. They may not have paid attention. There may be psychometric issues with the questions. All that stuff comes with survey data. And then last is there's limited theory on which to ground phase 1. And so that's why we're using a grounded theory approach, because we want to create theory around this. But it would be nice to have a little more theory to test. We don't have that right now, so we're creating it. But it is a limitation of the study. So last here, this is kind of my timeline for doing this. Phase 1, my hope is to start some pilot testing in the next few weeks just to make sure that our methods kind of make sense. IRB is ready to go. Hopefully we'll submit that in the next week or two. So we'll be able to get into full data collection in April and run that through the summer. The nice thing with rapid qualitative inquiry is we're analyzing while we're collecting data. So there won't have to be a separate big analysis phase here at the end. There'll be some, but a lot of that analysis will be done iteratively while we're going through the process. Then write that up at the end of the year for 2019. Be starting some phase 2 processes while I'm still running phase 1. So the design of the survey is mostly done now because it's based on past researched surveys. But there'll be some extra questions that I'll seed to that. So we'll need to do some phase validity testing on that. So we'll do that in August, September, and then hopefully disseminate the survey in October, November. And then do the analysis from December to April, and then run it up to the end to hopefully graduate by next June. Okay, so the last bit here is just to thank my funding sources, so the Foundation for Physical Therapy and then the National Library of Medicine Training Grant, as well as to thank my committee and then other individuals that helped me kind of shape the research idea to this point. So I'll pause there and we'll go to questions.
I guess since I have the microphone, I'll ask the first question. Very, very nice presentation and interesting. I'm trying to get a sense of, I understand the value of elucidating aspects of the physical therapy manager's environment. Where would you see, let's say you understand that really well and it's really useful and informative to them, where would you take this approach, these methods beyond physical therapy managers?
Yeah, so my initial focus when I started all of this a year and a half ago was actually on the frontline practitioner. Most of the research has really looked at a frontline practitioner and how do you manage quality. And I still think that's really necessary. But my suspicion is that that individual is so heavily shaped by the socio-technical system in which they work that studying them in isolation would give me confounded results. And so if I can understand this piece, now I can use those as some kind of base setting factors to say, great, I need to find some organizations that look like this, because my past research said this is a type of organization that affects the model, and maybe one like this and one like this. And then we can now look down at the provider level to see how they utilize the information. Secondly, the American Physical Therapy Association started a registry about 4 years ago that no one uses right now. Absolutely no one uses. It's the only PT-based, broad collecting registry that there is in the nation. I would like to help them with the process to say, we've understood here's some implementation things that can help people want to use these systems that are so robust and so well made, but they're not operationally fit into their work system. So can I learn from this model to create an implementation process that we can now, as you implement a registry into an organization, study that if we use these steps that we think we'll get out of this, do those get a better implementation than if you don't use them?
Thanks. I was thinking about your concepts of task and context and trying to understand where people's time fits into that, kind of how when people start to talk about time, and this may relate a little to Bill's question about like how you as an informaticist might try to eventually improve these systems so that these tasks could actually be done in these contexts that you now understand better. I'm curious, how are you going to ask them about time and make sense of time as it relates to the tasks or time that's available in their context, and to document that in a way that it's able to be talked about? Yeah,
so that effort expectancy speaks to that somewhat loosely. That's why the qualitative methods really allow us to explore that more. I can almost guarantee that as we go in, folks will say, it takes me 20 minutes to get to the number that I need to get to, and that's why I don't use the system. I suspect that's going to come out. And if that comes out, then we probably would, no amount of implementation is going to help a poorly designed system that just takes 20 minutes to get there. Now, there might be a training component that we have to help them get there faster, but that may be a system design thing. So I think a lot of that would come back to, if an implementation system can help it, great, but if not, to the developers of these systems to say, do you realize this came out as the biggest theme that people just aren't using your system because it takes them too much time? Can we work on finding ways to do this better? Or second would be, if there's competing priorities, I suspect we're also going to see that these managers sit in this middle of all of these competing tasks that come flying at them that they don't have any prioritization over. So we may go to the organizational leaders and say, your individuals just, we know they don't have enough time to do all of that, and you haven't clearly defined for them what's the most important thing and what's the next most important thing so that they can cut out the things that they shouldn't be wasting their time on. So make the system better, maybe some implementation training things that could help them, but I bet a whole lot of organizational leaders, man, there's some stuff you can do at this socio-technical level that will make your social system more conducive to getting things done faster. Yeah, did that.
Good job, Chris. Would you go back to your slide that has, let's see, where is it? Probably number 8 will do. Which occurs again somewhere, like 30.
Oh, slide 30 or slide 8?
Slide 30. I might not have the same version. That's the one. Okay. Yeah, so could you help me understand how, I'm looking at individual facilitating conditions on the bottom, and I would have guessed, so I must not understand what you mean by that, because I would have guessed that the individual age, gender, experience, and habit would be in there.
Yes.
So am I misunderstanding what individual facilitating conditions are, and how are you dealing with the collinearity and the problem of counting for the same thing more than once in your model?
Yeah, so well, I'll answer the first one first. So the individual facilitating factors are things like, did you get the training that you need to use this system? Do they give you the time in your day to use the system? So it really isn't system related, so you can't really speak to performance or effort expectancy, but it's did they give you the things you need in your day to use the system? So that's the definition of at least the 4 factor or the 4 indicator variables, questions that they have to serve it. That's what they're getting at. Now, with respect to collinearity, there's going to be collinearity in here, and that's the idea of this latent construct. Is the hope would be that these 4 factors that feed into individual facilitating factors all relate to one another much better than they relate to everything else, and that will be one of the psychometric tests that we have to do, is to understand, do we have discriminate validity, that those measures measure that latent construct better than they just measure everything else. But part of what SEM allows us to do is to look at that covariance and use that in our model creation.
So the individual facilitating conditions is not loosely defined variation at the individual level. It's very particularly defined as specific attributes at the exclusion of those attributes up there.
Correct. And really, the idea of the latent structure that we're using, we have a reflective model in SEMs. I'm not saying that these 4 questions are 100% all-inclusive of the concept of individually facilitating conditions. I'm saying the opposite way, that individual facilitating conditions would predict how you answer those questions. And so I'm not trying to say my questions are going to perfectly define each of these latent variables. I'm trying to say the latent variables all kind of hang around these indicators well.
Right. What I'm getting at is that many people believe that age and experience, for example, are individual facilitating conditions.
Yeah, and we will look at their moderation effect on them too. So that'd be one way to look at it. But we certainly could shuffle them around and put age in there and play if the exploratory part doesn't pan out. All right, thank you.